Good morning, everyone. Thank you, Dr. Blankenship, for that really kind introduction. Appreciate that. Thanks, everyone here, for having me here at SASIS 2016. It's truly an honor. I'm here to talk about Cangrelor is it a hype or hope in STEMI primary PCI. So at the end of this, I would like a quick show of hands. How many here use Cangrelor presently in any setting, or is it approved here yet? Okay. So first, reason for hope. There are some issues with platelet inhibition in ST elevation MI. This is a time when you need maximal antiplatelet activity and platelet inhibition from the get-go. And when you use PO antiplatelet agents, there are certain issues that come up, including delayed bioavailability, concomitant morphine use. Patients are often supine, don't swallow, throw up, etc. So there's a delay in absorption of the PO antiplatelet agent and subsequently a delay in onset of maximal antiplatelet activity. And once again, I'm sure most people here in STEMI settings don't necessarily call the surgeon, but there is the occasional time when you have to pick up the phone and say, well, I would really like my surgical colleagues to help me out during a STEMI. And during these instances, if you've already loaded the patient with antiplatelet agents PO up front, then oftentimes either the surgeon's going to really complain about it and for good reason with increased bleeding, oftentimes during CABG or needing more transfusion, or they're going to just sit on it for 5 to 7 days and then take the patient for surgery, often resulting in increased hospital stay. In comes Cangrelor, which is a direct platelet P2Y12 receptor antagonist given parenterally, quick onset and relatively quick offset, and it restores platelet activity essentially by 60 minutes. This graph essentially shows you once you give the bolus and the infusion, you get virtually really rapid platelet activity that's suppressed, and then once the infusion is turned off, by minute 60, you pretty much have restoration of antiplatelet activity. And this compared to your PO agents typically, which have slow onset, slow offset, and obviously you need to give it PO with all the limitations of taking antiplatelet agents PO. So the pivotal trials that led to approval of Cangrelor, actually the trial that led to approval and FDA approval in the US was the Champion Phoenix. The initial two trials, Champion PCI and Champion Platform, had a composite endpoint of death, MI, ischemia-driven revascularization, and are actually negative trials. They tweaked the endpoints a little bit and added stent thrombosis as one of the components of the endpoint, and also there were some differences in terms of when clopidogrel was actually given and the dosage of clopidogrel between the trials. And subsequently, that was a positive trial. And if you look at all trials together, all the Champion trials together, and the composite endpoint of death, MI, ischemia-driven revasc, stent thrombosis, it weighs in favor of Cangrelor compared to clopidogrel. Likewise, stent thrombosis shows a similar trend with Cangrelor outperforming clopidogrel. And if you look at the subsets, again, remember, these were not STEMI trials, but STEMI patients were included in the trials. And if you look at the overall trend, I mean, the STEMI patients did pretty much similar to the overall study population, with reduction in the primary endpoint that I just mentioned, and a reduction in stent thrombosis, and with necessarily no increase in the safety endpoint, which was severe to moderate bleeding by Gusto criteria. And this was in the Champion Phoenix. The pooled Champion trials essentially showed the same, no increased bleeding, and a trend towards better outcomes with Cangrelor compared to clopidogrel, both in terms of the primary endpoint and stent thrombosis. And subsequently, Cangrelor was approved by a narrow margin. And if you again look at this, why does this matter? Why do we say we want to hit it early and hit it hard? Because in the first hour or so is really the time that's crucial. And if you look at the first two columns and pay attention to it, that shows the composite endpoint of death, MI, IDR, and stent thrombosis. And the very first column is Cangrelor, and the second column is clopidogrel. Clearly, you see there's a big difference. And really, this is where the rubber hits the road. And and that's the reason for why we saw the curves kind of splay earlier on in the Kaplan-Meier curves. And what about just your newer oral antiplatelet agents? Now, the median STEMI door-to-balloon time, as was mentioned, I mean, there's been improvement in that, and actually in 2010, it's about 64 minutes in the US. And if you look at platelet reactivity at that time, platelet function at that time measured by platelet function testing, you see that around an hour, you still don't have optimal suppression of platelet activity with the newer agents. Further on, a lot of patients get morphine in the field, and that actually delays onset of oral antiplatelet agents. So, and doesn't matter whether you use prasugrel or ticagrelor. And I'm just going to touch on Plato here. Although this was a positive trial, if you look at it, there is no reduction in acute stent thrombosis. That is in the early period, less than 24 hours. Same story with Trident TIMI 38, where you looked at prasugrel and clopidogrel, no reduction in acute stent thrombosis. And then I'm just going to switch gears, talk about interprocedural stent thrombosis, which is basically during the procedure when you have thrombus formation. Typically, this is of low prevalence. That being said, in the Champion Phoenix trial, patients that had intraprocedural stent thrombosis tended to do much worse than those that did not. And this did not matter even if you got TIMI-3 flow at the end of the procedure. Those patients still did bad at 48 hours and 30 days. And of course, you had increased stay in the hospital, and cangrelor reduced IPST compared to clopidogrel in the overall Champion Phoenix trial. Now, so the conclusions, at least from this part, is that IPST is a major adverse clinical event, and no oral ADP antagonist has been demonstrated to reduce it. So, I mean, there's reason for hope. I mean, the pharmacokinetics seems to make sense, the dynamics make sense, clinical need is there, and I mean, obviously, they've shown that you have reduction in ischemic events with no increased risk in bleeding. So, it's all good. Well, there is always reason to be skeptical. And if you look, again, going back to the Plato trial, although this was, I did talk about that you didn't have acute stent thrombosis reduction, it was overall a positive trial. There was reduction in CV mortality as well as in the primary endpoint, which is a composite of CV death, MI stroke, where patients with ticagrelor did better than those in clopidogrel. And this was true, the hazard ratio was 0.84, both in the STEMI population, which was pretty much the same as in the overall group. This is a sub-study of the Trident TIMI 38 trial, which essentially showed what the overall trial showed, that patients who got prasugrel during STEMI did better than those that got clopidogrel. I'm going to kind of go a little bit faster in the interest of time here. So, and we talked about why we need to have early maximal antiplatelet inhibition, and there are some ways to work around it. You could use cangrelor, you could use 2B3 agents, you could give upstream administration, you could modify the dosage. I mean, doubling the dosage in ticagrelor has been shown to be effective. You could crush the drug and result in early absorption, early rapid absorption. And they have shown that doubling the dose of ticagrelor of 360 instead of 180 results in better platelet suppression compared to the standard dose of 180, as well as compared to prasugrel. And crushing the drug results in faster absorption, and you have more suppression of antiplatelet activity, of platelet activity compared to the integral pill, as shown in the Mojito trial. And pre-hospital ticagrelor has also been studied in STEMI patients. However, no one knows if crushing and pre-hospital is not being studied, but kind of makes sense. So what do we know? We know that oral P2Y12 inhibitors represents the current standard of care, although there is suboptimal platelet inhibition during and shortly after the procedure. But what this translates into clinical outcomes, to me, is not clear. And so if we really need to come, in the current day and age, if you want to say, well, you absolutely should be using cangrelor in every patient, what do we need? We need a trial that compares cangrelor versus ticagrelor or cangrelor versus prasugrel, and we don't have this kind of data. And if you look at the pivotal trials that essentially led to the approval of each one of these drugs, you can't extrapolate from there and just say that we got to use it in every STEMI patient. What do the guidelines recommend? So, at least in the European world, they recommend that you give a P2Y12 inhibitor at the time of first medical contact, and that's a 1B recommendation. And what do you give? You actually give one of the newer agents. You give prasugrel 60 milligrams or ticagrelor 180 milligrams, both with 1B. And you give clopidogrel 600 milligrams only when prasugrel or ticagrelor is not available or is contraindicated. And where does cangrelor fall in this whole thing? At least in 2014 when the guidelines came out, they basically were kind of agnostic about the whole thing, and they said, didn't really know what to do at this point, and they can't make a recommendation one way or another. And they kind of talked about there's no net effect on mortality, and benefit was mostly restricted to interprocedural stent thrombosis. And subsequently, for the non-STMI patients, there's a 2B recommendation, which is can't fault you if you do, cannot fault you if you don't do it. And what about the UK? So with the NHS, NICE basically recommended that cangrelor, once again, they said we can't really make any kind of recommendations, and also stated that it's really kind of a second-line treatment option after not in the same league as your oral antiplatelet agents. And so what don't we know? We don't know with the newer antiplatelet agents where exactly this falls in. What about with anticoagulants? What about GP2B3A inhibitors? And finally, it comes down to cost. What are the practical issues? Is the cost of a newer agent. So what do we know? As compared to clopidogrel, all three drugs are superior in reducing ischemic events, including stent thrombosis. So we have to do it at the point of first contact. I need like one more slide, please. And so the long and short of it is that given the lack of, okay, thank you, data, right now, I mean, you would use prasugrel and ticagrelor over clopidogrel if it is not contraindicated. And I would say the take-home points really is that it really comes down to this, like how much evidence do you need before you adopt a newer technology or drugs? So there is not solid data, in my mind at least, about just saying, issuing a blanket statement stating that cangrelor clearly should be utilized in every STEMI patient. I would strongly consider it if patients have not, if they are totally, if they have no antiplatelet agents on board, and I would probably want to use cangrelor in that setting in STEMI patients. But remember, all these trials were studied with aspirin on board, and when I say there's like virtually nothing on board and use cangrelor, that's totally off-label. I'm making it up. If patients are preloaded, I must still consider it on a case-by-case basis, especially let us say we're not sure if it actually went in, the patient threw up, and someone says, oh, they actually threw up on the way, they're unconscious, you're not sure about bioavailability, etc. And there are some times when you don't want oral antiplatelet agents on board, and then it's for that niche group that you might actually consider using this. And once again, if this were the same price or if it were free, I think people would use it a lot more liberally, but cost is a consideration in many parts of the world. Thank you.